So my name is John Newell-Price. I'm a professor of endocrinology in Sheffield, and I lead the Sheffield ENET's European Centre of Excellence for Neuroendocrine Tumours. And I'm also the chair of the UK and Ireland Neuroendocrine Tumour Society. And I'm very pleased to have been asked to give a talk today on how hormone syndromes may occur in patients with neuroendocrine tumours and how they may be actually affected and treated, and try to give you some insight as to why these things happen and then what we can do about them. So I'm going to give a very brief overview of neuroendocrine tumours, and then I'm going to talk about the various syndromes that may occur in patients with neuroendocrine tumours. So on this slide, I really summarize the types of tumours that can occur for patients with neuroendocrine tumours. And in this cartoon of the body, the size of the circle here just represents the percentage of the overall patients with neuroendocrine tumours that are affected by that type of net. So for example, the patients with small intestinal neuroendocrine tumours, about half of all the patients with neuroendocrine tumours, it affects the small intestine. Around about 17 to 20% of the patients with the pancreas, around 20% of patients with tumours in the lung. And these are the primary tumours in these different sites. There are some other sites where they are uncommonly affected as primary sites. But then in terms of where metastatic disease may be present, that is most frequently in the liver, here shown by these open circles, in the lung, shown by these open circles in the lung, and then less commonly, but still occur within the bone. So we have a wide range of different primary sites that may be affected, most commonly within the bowels and in the pancreas, and then metastases which may occur most commonly in the liver. And the issues with neuroendocrine tumours is that the symptoms occur because of a combination of either the tumour size itself or the production of various hormones, and that really is the subject of the rest of this talk. The problem is the word neuroendocrine actually isn't so helpful, because these are neither nerves and they're not normally part of the normal regulated endocrine system. And what these tumours are, or these cancers are, is that they have the potential to produce hormones. So for example, if you get a neuroendocrine tumour from the pancreas or the gut, these are organs that frequently secrete hormones. So if you get a tumour arising from those, it's not so surprising that that then may make the hormone that's usually made by that tissue. But actually, most of the neuroendocrine tumours we see don't produce hormones. If they do, they can cause severe symptoms, and that's due to unregulated excess hormone production. So normally, in the endocrine system, the regulation of hormones is very finely tuned and very carefully orchestrated and balanced within the body. But when you get these excess hormone productions, they're just producing many, many hormones without this being regulated, and that then causes harm and distress to patients. And it's really unusual that you would get a single neuroendocrine tumour, say for example of the pancreas, that would produce more than one type of hormone. So for example, very, very unlikely that a pancreatic neuroendocrine tumour that was making hormones would make both insulin and, for example, hormone gastrin. That would be very unusual. And so usually you just get one type of hormone being produced by these tumours, but in time they can switch from production of one to another. That occasionally occurs. So you'll have heard about the words functioning and non-functioning nets, and essentially this is just to do with whether they do or don't produce hormones. So this cartoon here just represents a neuroendocrine tumour. If it's non-functioning, and that's the majority, it's not producing hormones or not producing any extra chemicals into the bloodstream. Whereas a functioning tumour does secrete hormones to the extent that actually causes a clinical problem or a syndrome. The difficulty is we don't actually know why, when you've got a neuroendocrine tumour coming, for example, from the same organ, for example, the gut, why some of those do present with syndromes, but some don't. It's just an unknown reason, but certainly those that present with the syndrome pose greater problems to those patients and cause more issues for clinicians managing them. So how do hormones work? Well, if you've got a neuroendocrine tumor here and it releases a hormone depicted by this area in blue here into the blood, you'll see that the tumor is secreting this into the bloodstream, and the hormone has a particular shape, and that shape is important because the hormone will be in the bloodstream and it'll circulate around in the bloodstream until it will meet somewhere else in the body where that shape can lock on. This is called a receptor, and that's present in another organ in the body. So it's this recognition site here that then allows the hormone to have its effect. And then once it binds onto this receptor in another organ, there then is a hormone effect. And really, when you get excess hormones produced by the nets, they usually are produced, as I mentioned, from the organ that the net grew from, so the pancreas. But the important thing is that the action of the hormone is determined by which organ has the receptor for that hormone. So there are only certain receptors present in different tissues. So what this means is that a given hormone, when it's circulating around in the bloodstream, will only have an impact in certain areas depending on whether this receptor is present. And I want to use this schema to illustrate a range of different hormone syndromes associated with neuroendocrine tumors. So here is an example of a patient who may have a gastrinoma. So these are uncommon. About 1 to 2 people per million population will present per year, so they're uncommon. And the neuroendocrine tumor here is secreting the hormone gastrin, and these usually arise from either the pancreas, shown in here, or perhaps the duodenum, which is just the first part of the bowel immediately after the stomach. And the gastrin will then bind to its receptor, and the receptor is present in the actual stomach itself. And the consequence of that is that it causes a high production of acid. Now, gastrin is a hormone that normally does this, but in a regulated fashion, whereby there is a feedback so that when the production of acid is high, it then feeds back normally to switch off the production of gastrin in a regulated feedback loop. But when you've got a neuroendocrine tumor producing the gastrin, it just keeps pushing out the gastrin and so causes a high acid output, causing profound indigestion. It can cause bleeding in the gut, and of course it can cause diarrhea as well. And we treat this by giving high doses of proton pump inhibitors, the drugs like omeprazole or lansoprazole and things like that. Or if it's possible to identify it, maybe possible to identify the neuroendocrine tumor and remove it. And occasionally we may even use somatostatin analogs. I'm going to come back to those at the end of the talk. So here's an example how you have this hormone binding to this receptor, which happens to be present in the stomach, to cause this particular syndrome, which is also known as the Zollinger-Ellison syndrome. Insulin-secreting tumors arise from the pancreas here, and the insulin is secreted into the bloodstream and acts predominantly on the liver and in the muscle, and the consequence of that is to lower the blood sugar. So patients with insulin-secreting tumors may present with the signs and symptoms of a low blood sugar, including fast heartbeat, sweating, confusion, collapse, and things like that. So it's a very serious condition of the low blood sugar, but it's due to the fact that you've got a tumor that's actually arisen in an organ that would normally produce insulin. But of course, this again is being produced in an unregulated fashion, because normally when you get a low blood sugar, this is sensed and the insulin levels will drop. When patients have got an insulinoma, the level of insulin still gets secreted, and therefore the blood sugar stays low. And this affects about 1 to 2 new patients per million population per year. Vasointestinal active peptide, or VIP, are from tumors predominantly of the pancreas, but can also be in the first part of the duodenum, The VIP binds to receptors present in the bowel, and this results in profuse watery diarrhea. And that can cause a huge problem for patients. It's because the receptors present here, the VIP acts on it and effectively induces a syndrome that's not very different, unfortunately, to cholera. This, fortunately, though, is not common. It's an unusual problem, but when present, really is very profound for the patients who experience this. So glucagon-secreting tumors, or glucagonomas, they arise in the pancreas. The target is the skin and the liver, and the reason being is because these receptors for the glucagon are present in these sites, and that causes high blood sugar, because the glucagon opposes the action of insulin and also causes this, at times, very unpleasant rash in the skin. And again, if the area in the pancreas can be identified and removed, then that can be effective at treating it. And otherwise, we can use things like somatostatin analogs to lower the level of glucagon and help treat the patient. But you'll notice that these really are an uncommon type of tumor. So then you have NETs and hormones, and they produced in parts of the body which wouldn't normally produce that hormone. So a good example of this is in pulmonary neuroendocrine tumors or pancreatic neuroendocrine tumors that release a hormone called ACTH, or adrenocorticotropic hormone. That acts at the adrenal gland to give high cortisol levels, and that produces a thing called Cushing's. But these tissues do not normally make ACTH. So this is an example where you have this being produced in a tissue where really it shouldn't normally be produced, but that occurs, but it's very uncommon. And similarly, you can get the production of another hormone known as parathormone-related peptide, and that binds to receptors in the bone and kidney and causes a very high level of calcium. So again, these are uncommon, but they're occurring in tissues which wouldn't normally make these hormones. But their effects are still being driven because the receptors for these hormones are present in different tissues, and they're being released in this unregulated fashion that means they keep on being produced and keep on giving problems unless the tumor can be removed or the levels of these hormones can be lowered. So carcinoid syndrome is one of the more common syndromes of a high level of secretion. In this situation, you've got a neuroendocrine tumor cell. Most will be in the bowel, but they can also be in the lung, and they cause the extra production of 5-HT, or 5-hydroxytryptamine. So this is serotonin. And in addition, there's some other substances which are released at the same time. Normally, the serotonin, when it's produced by these cells in the tumors in the gut, they then pass through the circulation, and the gut circulation drains to the liver. And the liver is normally then extremely good at breaking down the serotonin and preventing problems. The problem then arises, though, is when patients have got metastases in the liver, these can then release the serotonin into the systemic circulation, and it can go on to have the effects. So the effects can be because the serotonin receptors are present in the gut, and they cause flushing and diarrhea and dyspnea, etc. And that's some of the other active substances that are released. But the serotonin itself can also bind receptors in the heart valves and cause fibrosis, and also cause problems in other areas around the bowel, causing fibrosis. And fibrosis is this reaction where you get an increase in the sort of thickening in and around the organs where that occurs. So in fact, carcinoid syndrome typically only occurs once there have been some metastases to the liver, because otherwise, if that hasn't happened, the liver can metabolize all this extra serotonin, and as a consequence, the patient doesn't experience the carcinoid syndrome. The other time that the carcinoid syndrome can occur is if there is some metastases from the original tumor to what we call the peritoneal lining, which is around the gut, because that actually drains directly into the systemic circulation and not via the liver. So if you like, it bypasses the liver. That's less common. the fact that the serotonin is then metabolized to 5-hydroxyindole acid is used in clinical practice, because this then passes out through the urine, and that's collected as a urine test that allows us to monitor the level and give us an idea of how effective our treatments are, and indeed how high the levels are and what impact that may be having in terms of the symptoms the patients are experiencing, and also the potential risk from carcinoid heart disease. So that's the carcinoid syndrome, and you'll be aware that at times when patients are then subjected to operations, if we know the patient has these types of tumours, we make sure they received good intravenous infusions or a triatide to make sure they reduce the risk of a carcinoid crisis here, which can occur with a big release of the serotonin, which can put up the heart rate, drop the blood pressure, and make the patient unwell. So when it's recognised, we've now got very good protocols to make people safe for operations. So with that background, it then leads into some of the principles of how we treat patients with NETs, because in fact they're based on understanding how these hormones are being secreted. If it's possible, then surgical therapy will form a very important role. If the tumour can be identified and it can be completely removed, that can cure the patient. But even in the absence of a cure, at times we would use debulking treatment to actually reduce the amount of hormone that's being secreted and reduce the amount of tumour that's left. If there are symptoms, then we use symptomatic treatment, and we can use these things in parallel to control the hormone secretion. And this is using these compounds called somatostatin analogues, currently either octreotide or lanreotide, and occasionally in some places there may be the use of pasireotide, although that's not used for this in the UK. And there is also antiproliferative therapy, some of which are the somatostatin analogues, but there are also other treatments that we can use in this circumstance. So I just want to spend a moment to talk about how the somatostatin analog works and the principle underlying it. And in fact, it comes back again to thinking about receptors for hormones, because somatostatin is an endogenous, that means a hormone that's present in the body. It usually has a very, very short action measured in minutes. And what it does, it tends to switch off the production of nearly every other hormone when the tissue has the receptors present for somatostatin. And that fact has been manipulated by creating synthetic analogues of somatostatin, that's octreotide and lanreotide, which last for much longer but still bind to those receptors and allow the hormones to be switched off. So here is the somatostatin analog, and here is the somatostatin 2 receptor. And because of the shape of the analog and the shape of the receptor, represented in cartoon fashion, it's able to bind this. And it just so happens that on the cell surface of many, many neuroendocrine tumors, it has these somatostatin 2 receptors. And as a consequence, when somatostatin is given, it can bind these receptors, and the action of that then is to switch off or at least reduce the hormone secretion from those tumor cells. And in addition, the added bonus is that they have anti-tumor and anti-proliferative effects. And nowadays, as many will be aware, there are depot monthly injections of these somatostatin analogues, and that then makes it possible to treat the carcinoid syndrome, to treat patients with secretion, for example, of VIP, of glucagon, etc., and actually to lower the hormone levels and improve the patient's conditions, either before surgery, or if surgery is not possible, or if there is disease which can't be fully removed. And we also use the presence of these receptors to use the newer treatment, the treatment of peptide receptor radiotherapy, most commonly with lutetium. And here you have the somatostatin receptor, you have an analog that will bind that receptor, and then it's linked up to what's called a chelator that can then hold this radioactive moiety here, this lutetium. And because of that, it's able to bind here. And what happens is that once this is bound, the receptor is what's called internalized. The binding then triggers a mechanism whereby this whole receptor and bound complex is taken into the cell. And because of that, this is radioactive. It delivers radiation directly to the cell. And this is short distance radiotherapy that affects just the tissue that it's delivered to. So it's, if you like, a magic bullet being delivered to the tumors which express these receptors. So here is an example where understanding the receptor allows this particular treatment to take place. So in summary, many, but not all nets, they release hormones, and these can have action elsewhere in the body, and that's dependent really on where the receptors are. And it's fortunate that the nets themselves have hormone receptors, because that's now been possible to manipulate to be able to use either somatostatin analogs to switch the production off, or if patients progress despite being on a somatostatin analog, they can then have peptide receptor radiotherapy. And the somatostatin analogs work by switching off the hormone release, and also they have some anti-proliferative tumor activity. And really, it is the fact that they are present that then allow us to perform the peptide receptor radiotherapy. So I hope that summarizes the ways in which the hormone systems work in these tumors, and I hope that it's clarified things, and I thank you for your attention.